Hi everyone. Let me just flick through there. Sorry about that. So my name's Rae. I am a consultant and a senior lecturer in infectious diseases at St George's in London. I also have worked for many years in South Africa, probably around a decade, and I'm now officially an honorary senior researcher at WITS. And I'm going to speak today about combination antifungal therapy. I was going to start with this. I was going to put this up actually earlier, so to kill the boredom of waiting for the talk. This is a Twitter rant I found from Brad Spellberg, who you may have heard of in the context of he talks a lot about shorter antibiotic courses of treatments, but his Twitter feeds are quite entertaining. And he does a Twitter rant here about antibiotic combination treatments. So he lists the philosophical reasons. I'm obviously not going to read it all. Philosophical reasons here for using combination therapy for infectious diseases, as we have some precedent in doing in HIV, in hepatitis, in tuberculosis. But the reasons he gives here are to prevent the emergence of antibiotic resistance, to improve outcomes, and to broaden cover. And he goes on to sort of debunk these reasons for a majority of infections, quoting the poor evidence in bacterial infections. I quote him here: how much freaking failed studies do we need? But in the end, he does concede that there is good evidence in using combination treatment for fungal infections. So that's what I'm going to focus on. So I thought I'd start by discussing some of the evidence about cryptococcal meningitis, which we are all very familiar, touching on Aspergillus and mucor, and then go on to look at the rationale for extracting the approach of using combination antifungal therapy to invasive candidiasis. And then I'd like to introduce a newly funded programme of work, which is to be based in South Africa, called Combat Candida, and I'd love to discuss with you further if you've got some time at the end. So the earliest evidence I could find for a synergistic interaction between antifungals action on Cryptococcus in vitro and from mice was from the 1970s. So on the left here, I've showed some survival curves of improved survival in mice using amphotericin with flucytosine. And on the right, this is in vitro time kill data, so time kill assays showing a synergistic interaction, again, between the same drugs, amphotericin and flucytosine in vitro. In 2012, a phase 2 trial in Lilongwe was conducted by colleagues of mine, Tom Harrison at St George's, with a team, and they found a more rapid clearance of Cryptococcus from the CSF using combination treatments shown by serial lumbar punctures and plotting the colony forming units each day to calculate early fungicidal activity, or EFA. And they also showed that survival was improved by the addition of flucytosine to either fluconazole or amphotericin B. And here's a slide I stole earlier from Tom Harrison himself this morning. And this shows how EFA has been used in serial RCTs, mainly led by himself, assessing the drug combinations for cryptococcal meningitis in various trials. And it's culminated in the current recommendation showed here at the bottom, using a single high dose of liposomal amphotericin B in combination with flucytosine and fluconazole, which is the current recommended treatment for cryptococcal meningitis. So all of this preclinical and clinical trial evidence over the past 2 or 3 decades in cryptococcal meningitis has really revolutionized the treatment of HIV-related cryptococcal meningitis. This is from a publication from last year calling for the implementation of this evidence base. So this was called Ending Cryptococcal Meningitis Deaths by 2030, sponsored by DNDi and various institutions. So we know that combination treatment now with amphotericin, fluconazole, and flucytosine can improve a patient's chances of survival from around 20%, this is real world data using fluconazole monotherapy, to around 70 to 80%, as has been shown in randomized trials and in real world data, including from South Africa. This is the ACTA trial led by Tom Harrison and Sheila Malloy, where 5 different drug regimens were tested in 3 African countries, and this showed that flucytosine was an essential partner drug in a backbone of critical meningitis treatment. And it was a component in 3 of the best performing regimens, reducing mortality to around 20 to 30%. And finally, this is the Ambition trial, which was published in 2022, led by Joe Jarvis and Tom Harrison, showing non-inferiority of a triple regimen, including a single high dose of liposomal amphotericin B, flucytosine, and fluconazole, which drove a mortality reduction to around 25%. So we are now testing an oral combination antifungal treatment for asymptomatic cragemia, so patients without meningitis, because as some of my PhD work showed in South Africa, these patients still have an excess mortality driven by cryptococcosis, and fluconazole plus flucytosine is being tested in the EFFECT trial led by Nilesh Govender and Sheila Malloy, and with many of you involved at these South African sites. This is a phase 3 randomized controlled trial. So that's a summary of combination antifungal treatment for cryptococcal meningitis, some of the pre-clinical and the clinical trial data, including current trial. So we think of, if we think about the mechanisms of action of these drugs that I've mentioned already, antifungals that we use for cryptococcal meningitis, this might explain some of the synergy between them. So amphotericin B disrupts the cell wall. It's meant to sort of attach as a sponge now and cause pores to form in the cell wall. And this might potentiate the action of flucytosine, which is a prodrug 5-FC. It needs to enter into fungal cells through the cell wall and be converted by cytosine deaminase to 5-FU, 5-fluorouracil, which then works on the nucleus, inhibiting DNA and RNA synthesis. And some of that early work that I mentioned at the beginning from the 1970s actually used carbon-labeled 5-FC and showed that the addition of amphotericin B with 5-FC in a broth together improved the uptake of 5-FC into yeast cells. This was actually in Candida as well as in Cryptococcus cells. Another interesting outcome of using combination treatment in Cryptococcus is the suppression of heteroresistance. So heteroresistance is an intrinsic phenomenon. We see it in bacteria. It's observed in Cryptococcus and also in certain Candida, so I'll discuss it later. So heteroresistance is this phenomenon where a small proportion of cells are resistant to drug concentrations that are above the minimum inhibitory concentration. So in the presence of drug, this is an unstable mechanism. The populations expand in the presence of drug, and then there's concern that this can lead to treatment failure. So in this study by Neil Stone, who was a PhD student at the time at St. George's, he showed that patients treated with fluconazole monotherapy, this was done in Tanzania where that was routine care, had an increase in heteroresistant populations, shown here on the y-axis, growing in their CSF, and that was associated with treatment failure. However, the combination of fluconazole and flucytosine suppressed that level of heteroresistance, and he also replicated what he saw in clinical cases in vitro. I think it was done on drug agar or in broth, I can't remember. But he replicated this in vitro and showed that the heteroresistant population, shown by this red dotted line, increased during fluconazole monotherapy. You can see that red line going up, and then when adding the 2 drugs together, it was the heteroresistant line, the red dotted line, was suppressed. And this is a finding which might be relevant when we come to think about Candida. Okay, so what about invasive aspergillosis? As I said, I'm just going to touch on aspergillosis and mucormycosis before moving on to Candida. So first-line treatment for aspergillosis is voriconazole, as you know, with amphotericin as an alternative. And currently, combination treatment is not recommended routinely. The addition of echinocandin is recommended where you're really struggling as salvage therapy. But invasive aspergillosis, as you know, I'm sure, is associated with very poor outcomes of mortality of 43 to 82%. And there is some quite compelling evidence that using combination therapy could improve the treatment of IA. So this has come from in vitro and animal models, showing good outcomes with the echinocandins, either with amphotericin B or with azoles. In a retrospective review of cases of invasive aspergillosis, Kirsten Ma showed a dramatic reduction in mortality using vori, and yeah, that was vori and caspofungin. However, when that went on to be tested, so the combination of voriconazole and nidulafungin went on to be tested in an RCT. This narrowly missed statistical significance for showing a survival benefit. So they randomized 142 participants. They had either a hematological malignancy or hematopoietic stem cell transplant associated in invasive aspergillosis. So they randomized these patients to either vori or vori plus nidulafungin, and the 6-week mortality reduced from 27.5 to 19.4%. So that is almost a 30% mortality reduction. It's quite a significant, dramatic reduction. But unfortunately, this trial was underpowered. The mortality in the control arm was higher than expected. And so it sort of just missed the statistical significance mark. And this was 2015. It's a very long time ago. But it's left this question unanswered. But in my opinion, this is a question that shouldn't be abandoned for this very severe illness with poor outcomes. And then moving on to mucormycosis, there's no randomized trial evidence for this disease. It's hard to study in trials in its rarity. But again, it's an infection where monotherapy is recommended. High mortality is observed between 40 to 80%. These are very, very sick patients. And combination treatment is still in question. It's frequently used in and reported in case reports and case series. But again, there's no randomized findings. So there's very varied findings about combination treatment from animal models and case series. The largest single-center retrospective study of 106 patients with hematological malignancies or stem cell transplants compared patients who'd had any kind of monotherapy versus combination therapy and showed no difference in 6-week survival. But then there's been a recent systematic review, using data from over 5,000 patients who had outcomes reported in the literature, comparing again amphotericin B monotherapy with amphotericin B plus fluconazole, very large numbers of patients with a very dramatic observed reduction in mortality from 31.5% to 6.6%. But again, this is all retrospective data and very difficult to interpret and apply. So perhaps, again, a space where a clinical trial is warranted. Okay, so made it to invasive candidiasis. Candida, as you know, is a gut and skin commensal, which can cause a deadly fungal sepsis in critically ill and immune suppressed patients. It has a very high mortality of up to 77% in certain contexts, and there are diminishing treatment options due to our very limited armamentarium of antifungals and the increasing resistance that we are observing worldwide. So I must admit, having studied Cryptococcus, I always thought of Candida as a rather boring yeast, but it is becoming an increasingly sexy and hot topic, mainly really because of these alarming trends that we are seeing in antifungal resistance. So antifungal resistant Candida were deemed an urgent and serious threat to global health by the US CDC in 2019, and I'm going to show you why. So there are only 3 classes of antifungal used for candidiasis: polyenes, amphotericin B, that's limited by toxicity and due to cost, and then azoles and echinocandins. So the increasing use of azoles over the past 2 or 3 decades really has led to this epidemiological shift towards, or away from Candida albicans towards Candida species which have intrinsic resistance to azoles. And we are also seeing the increase of secondary azole resistance. Finally, our reliance on echinocandins as our first-line treatment is now a ticking time bomb for the final useful class of antifungals we can use for candidiasis, with rising secondary resistance to echinocandins now being observed, although still quite rare. It's concerning. So on top of all this, we've now got the emergence of frequently multi-drug resistant species, Candida glabrata and Candida auris. This is a map from a recent Nature Comms review, which shows this epidemiological shift away from Candida albicans. It's more dramatic, or it's more of a concern in African countries. I mean, ironically, they've labeled this entire continent Africa, but actually the data's only here from 3 countries. But anyway, it also shows reports of azole-resistant Candida parapsilosis and Candida auris in all the countries coloured orange and red, which is basically all of them with data. And it really kind of underplays the massive epidemic of azole-resistant Candida in South Africa by labelling it orange, which represents reports of Candida auris and Candida parapsilosis with gonosol resistance of over 10%. I'm just going to go on to show you why that is a slight understatement. So in fact, Candida parapsilosis is now the most frequently isolated species in bloodstream infections in South Africa, and around 2/3 are actually resistant to fluconazole. This is unpublished data from the amazing NICD surveillance data. Azole-resistant Candida parapsilosis is otherwise reported in big outbreaks from countries across the world. Now on to talk about Candida auris. Candida auris now causes around 1/3 of Candida bloodstream infections in South Africa. This is data that was put together by Charlotte Rabel, who was recently here on a sort of placement from the Institute Pasteur, but has recently just left Johannesburg. But this is all data from the NICD with a figure credited to her. The NICD and germs data, by the way, is the best Candida surveillance that exists anywhere in the world. These are incredible numbers and incredibly accurate data, and it's really has driven amazing results, and it's impacted the funding and the studies that have come out of this. So as you can see, Candida auris started to be a problem 2016, 2017. I left South Africa in 2019, and I'm not saying this has anything to do with me leaving, but it has really taken over since then. And as I said, auris is now causing 1/3, almost, is the leading cause of candidemias in South Africa, although, we get to see the trends properly. And this map by Erica van Schalkwijk, also at NICD, shows here that the hotspot of Candida auris infections is around the Gauteng region, and in fact, mostly in Johannesburg. In comparison, surveillance in the US is much less comprehensive. And note that I'm not going to show you any data from the UK because it's embarrassingly sparse. But there are rising numbers of cases of Candida auris infection across Europe and the US, which are really making people sit up and become quite twitchy about this matter, since really, it's clearly only a matter of time before we see the explosion of auris worldwide that we've seen in South Africa. So as a result of the rising incidence, the high mortality and the rising levels of resistance, these 5 Candida species were named as high or critical priority pathogens in the WHO priority pathogen, the WHO fungal priority pathogen list, with an additional Candida down here in the medium priority group. So they are very hard hitting now in the sort of the pathogens driving funding and research. There's an urgent need to address research to optimize the prevention and treatment of Candida or invasive candidiasis. And of course, there are evidence-based interventions for invasive candidiasis for improving outcomes and preventing the spread of infection or preventing the spread of resistance. So these are early, getting in early with antifungals, using echinocandin as first-line treatment, removal of lines, etc. But I'm going to discuss combination antifungal therapy as a potential approach to invasive candidiasis, which I think needs urgent investigation. So in this recent review in OFID, I argue that combination antifungal treatment could be a solution for these 5 reasons. So firstly, to improve the penetration of antifungals to different body sites. Secondly, to decrease resistance selection. Thirdly, reduce stress adaptation. Fourthly, increase fungal clearance. And fifthly, to potentially decrease required doses of antifungal drugs. So I'm going to just go through these reasons, just showing some evidence about what the problem is with using monotherapy related to these particular issues, and then move on to discuss the potential of combination treatment for addressing these issues. So firstly, just talking about drug penetration, and I'm focusing here on echinocandins as the internationally recommended first-line treatment for invasive candidiasis. Echinocandins have extensive protein binding, shown here in this table, and in fact, the fact that they are protein bound and also metabolized by the liver largely. You can see the protein binding levels here compared to flucytosine. I mean that they actually penetrate fairly poorly to some of the body sites which are important in invasive candidiasis. So the urine, the eyes, the GI tract, mucosae, and the CSF. And so that's a problem for a yeast which colonizes many of those sites and also can also obviously cause disseminated infection to those sites. So the low concentration of echinocandins at some of these body sites might also mean that antifungal monotherapy can drive antifungal resistance in these sites where Candida can persist at low drug levels. We know that drug resistance can either be intrinsic or acquired across the board, but in Candida, this can be associated with genetic mutations. For example, ERG11 mutations, which increases the synthesis of the azole target ergosterol and reduces binding. So that's how it's resistant to azoles. And then for echinocandin FKS, hotspot mutations encode a subunit of the target BD glucan synthase, and resistance can also be caused by copy number variations or transcription factors such as PDR1, which increases drug efflux. So low levels of antifungal exposure in underpenetrated sites may allow Candida to persist, selecting out any intrinsic mechanisms or acquired genetic resistance mechanisms and making them predominant in these sites. there are many cases reported where patients treated for drug-susceptible Candida subsequently have drug-resistant Candida isolated from sites such as urine or intra-abdominal fluid or peritoneal fluid. And in fact, unpublished data from, again, from NICD has showed that all param-resistant Candida auris in South Africa has been isolated from urine, which implies, although it's not prospective data, that resistance has evolved or been selected for in the context of drug treatment. About those extra bits, but these figures just show the data from a prospective study from Denmark published by Jensen et al. This was data where patients with Candida glabrata bloodstream infections had serial oral swabs taken after treatment. And they found that on the left, patients who had treatment with fluconazole for more than 7 days had fluconazole-resistant Candida glabrata. Sorry, the proportion of fluconazole-resistant Candida glabrata increased from 4.8% to 29.4%. And on the right, this shows patients who were treated with a fungin for more than 7 days, again showing an increase in the proportion of resistant Candida glabrata from 4.8% to 29.4%. So that's some prospective data showing potentially the selection of resistance Candida glabrata after treatment. This is data from CandiRes. CandiRes is a multi-site cohort study of UK ICUs led by Professor Tahana Bicinic at St George's, and I am marginally involved in this. We're assessing here the impact of antifungal exposure by performing serial colonizing swabs from the oral cavity and perianal sites every 3 to 4 days. This is from high-risk patients in ICUs. So on the left-hand side, I'm showing you here the serial MICs, so along the x-axis of Candida species. So this is fluconazole at the top and a fungin at the bottom. And you can see that these are all patients who've had more than 3 days of antifungals. So for fluconazole, we found more than 4-fold increase in MIC, shown by these coloured lines, in 15% of patients who've been exposed for more than 3 days of fluconazole, and in 11% in patients who've had fungin for more than 3 days. This is compared to the unexposed population, where we see an increase in MIC in 2% cases. So this is a significant association between antifungal exposure for fluconazole and nearing significance with fungin. Whole genome sequencing has then identified resistance mutations, including the ones that I've already mentioned. So that's the CandiRes data. Going back to South African data, this is a slide again from Charlotte Rabel, who has recently assessed the effect of prior antifungal exposure on the risk of non-susceptible Candida bloodstream infections from over 1,000 cases documented by NICD surveillance, and showed that prior antifungal exposure increased the odds of non-susceptible candidemia by around 2-fold. Okay, so moving on to stress adaptation. So in addition to MIC measurement, there are other measures of of Candida adaptation which might be induced by antifungal exposure. These are not measured by our routine measurements of MIC in the lab. These are termed tolerance and heteroresistance, terms which you might be familiar with also in bacterial infections. For example, these images here show the effect of fungin on cell wall remodeling. and chitin synthesis, shown in the bottom panel here, is thought to occur as a stress adaptation leading to tolerance. Tolerance can be measured by the slow growth of Candida at drug concentrations above the MIC, shown here by the colonies growing next to the E-test strip, and also measurable in broth microdilution. And then heteroresistance, as I mentioned in the context of crypto, is an intrinsic phenomenon exhibited by bacteria, but also recognized in some fungi, where a small proportion, small subpopulation of Candida, less than 1% of that growing on the drug-free plate here, grows in the presence of drug, and then can expand in the presence of antibiotic exposure. So this is so in bacterial as well as fungal infections. But this is unstable, and then the population can then retract when the drug pressure is removed. The mechanism in Candida is unclear for heteroresistance, but in crypto this is related to aneuploidy, and it's probably in Candida an interplay between genetic and epigenetic mechanisms. So we have measured heteroresistance in isolates from the CandiRes study. This is unpublished data by Ben Caswell and Claire Logan, who both have been involved in working on the CandiRes study. And they essentially quantified heteroresistance by a method called population analysis profiling, plating serially diluted isolates taken from patients in the CandiRes study who were exposed to antifungal, and then plating them onto increasing concentrations of drug and counting the colony forming units which grow on these drug plates. In these graphs, you can see that there is an expanding population of heteroresistant subpopulations in the serial swabs taken at day 0, day 5, day 29. This is when the Candida then becomes fully resistant. So these are populations growing above the MIC. They expand following exposure to fluconazole, and again shown following exposure to a nidula fungum. It's unknown what the clinical implications of these stress adaptation mechanisms are, particularly in heteroresistance, but this is a very cool recent paper published in Nature, which measured mycofungin heteroresistance in Candida parapsilosis growth from stool samples taken from patients undergoing allogenic hematopoietic cell transplantation on mycofungin resistance. And they found that heteroresistance in stool samples, so you can see here the heteroresistance seen in the stool samples was then associated with breakthrough bloodstream infections, and they genetically linked these isolates from the stool and from the blood, showing that they were genetically linked strains of Candida parapsilosis. So implicating heteroresistance as a cause of breakthrough drug and drug failure, essentially. Okay, so so far I've discussed combination antifungal therapy, which might improve the penetration to sites where Candida persists. It might protect against the selection of drug resistance and might protect against the stress adaptation, which we think is caused by exposure to drug monotherapy. So finally, I'd like to talk about the way that combination antifungal therapy might improve the rate of clearance of Candida, potentially enabling lower doses of drugs to be given, potentially toxic drugs to be given. So drug interaction is often measured by something called fractional inhibitory concentration index, or FICI, F-I-C-I, shown by this graph. And this essentially measures the fraction of the MIC in the combination of drugs compared to the MIC of each drug alone. And find synergy, the index is a measure of less than 0.5, shown here by the green line. It shows an additive interaction if the FICI is 0.5 to 4, and then antagonism if the index is more than 4, shown here by the red line. Okay. So in this review article, we looked at all the current in vitro, animal, and clinical evidence in with using different combinations for Candida infections, and we found there were very varied interactions depending on the different drug concentrations used, the different obviously doses of drugs used, the different strains, the different species. We made these charts here showing the published data on various combinations. So this one shows the combination of echinocandins and azoles, and in the in vitro column, each isolate is represented where the drug combination was either found to be synergistic in green, additive with the orange dots, and then antagonistic by the red dots. So you can see that here the combination of echinocandins and azoles, all the various isolates that have been published, synergism was found in around a quarter. The majority of the interactions were found to be additive, and there were also some antagonism noted. The dots, by the way, with the black circles around them, are all Candida auris isolates. So this was, this has really been increasingly used, trying to find combinations that work against Candida auris. There were also 4 studies in mice showing some encouraging results, but no clinical studies of this combination. Then we looked at amphotericin B in combination with the echinocandins and azoles. And again, there was a majority additive interaction between this combination, between amphotericin and echinocandins. There was synergistic interaction in 5 mice studies. With azoles and amphotericin B, there has been more concern about antagonism. You can see a sort of greater proportion of red dots there. There have been antagonistic interactions seen in animal studies, but actually, when the largest randomized trial combination treatment actually showed improved eradication, so probably showing that what we see in vitro and in animals doesn't necessarily translate into clinical studies. And finally, the combinations with flucytosine, which again show largely synergistic and additive interactions in vitro, fairly encouraging reports in animal studies, and clinical trials have been encouraging, but really too small to show a mortality benefit. I've summarized here the clinical studies to just look into those in a bit more detail. So there have only been 3 randomized controlled trials. The most recent one was in 2003, almost 2 decades ago. And just to highlight again that all showed earlier elimination or a greater proportion of Candida clearance from blood cultures or sterile sites, but no mortality benefits seen in any of the trials. These are quite small numbers. The largest trial had a total of 219 patients, and all use amphotericin B, which was associated with nephrotoxicity across the board. So clearly a new trial is required, and we feel that on balance, the priority immediately should be for testing this combination of echinocandins and flucytosine for the treatment of invasive candidiasis. The reasons for this are that echinocandins are the current first-line treatment, both in international as well as South African guidelines. I mean, this was a guideline focused on Candida auris, and really looking at the levels of azole resistance in South Africa. The echinocandins are a sensible first option if you have a patient with Candida bloodstream infection. Flucytosine might be a complementary mechanism of action to echinocandins, which work again on the cell wall, allowing potentially the entry of flucytosine into the cell. And they also have complementary PK attributes. We've discussed the PK of echinocandins already, with problems with tissue penetration due to high protein binding. Flucytosine is a small water-soluble molecule. It's very protein unbound, and therefore it's got good penetration to those body sites where echinocandins might struggle. Currently, the MICs to flucytosine in Candida are very low. There are no official breakpoints, but the median MIC in Candida auris in South Africa, around 400 isolates were tested, and the median was 0.25. Finally, flucytosine is a safe, licensed, and becoming available worldwide with generics, meaning that this is an affordable drug as well. Just to mention about flucytosine access, these are now the countries that flucytosine is now registered in, noting that all of these countries were grey in 2017. So it's been a registered drug driven by the success in cryptococcal meningitis and the advocacy that's some of it's come out of St George's as well. However, as you know, more work is needed, and on the ground, access to flucytosine remains challenging. I just wanted to show these maps, which were created by a master's student that recently worked with me and performed an online survey. So this is data from Charlotte Dines. Her survey went out and got 459 respondents from clinical practitioners across 32 African countries, and it showed that fluconazole is still really the only widely available antifungal across these African countries, which in the context of what the azole resistance rates I've showed you earlier is really quite concerning. And it also shows that flucytosine access is improving, but still reported as low as 20% in some countries. So back to echinocandins and flucytosine for Candida. This is data from colleagues in Exeter who've used in vitro checkerboard experiments to show that this combination is additive or synergistic. So showed here on the left-hand side with these this funny looking graph, and also in this video, which shows microfluidic analysis of the doubling time of Candida auris, which is found to be significantly slower using the combination of Anidula fungin and 5-FC. She also tested other drug combinations. Monogepix notably looks also very promising, but obviously is not an accessible drug yet. Colleagues at St George's have also used a Galleria model of Candida auris infection to show that the combination of Anidula fungin plus flucytosine was associated with improved survival in the Galleria, showed it by the grey line here, and also in clearance of Candida auris in tissues, showed here by the colony forming unit counts in the grey bars. And finally, this is work by myself and Ben Caswar, who's a PhD student now at St George's. We've used in vitro evolution of used in vitro evolution experiments to show that flucytosine suppressed Anidula fungin heteroresistance that we observed in a Candida auris isolate taken from a clinical series. We used a similar methodology that the work by Neil Stone I showed at the beginning in cryptococcosis, which was passaging the isolates of Candida auris in broth, which was either drug-free or had Anidula fungin on its own, or had 5-FC on its own, or a combination of the two drugs on its own, put into a shaking incubator, and then taking out an aliquot of this broth daily and plating onto drug-free or Anidula fungin infused agar. And as you can see in these graphs, we found that the combination shown by the blue lines suppress not only the growth of Candida on the drug-free plate, but also the heteroresistant growth observed in the Anidula fungin infused plates as well on the right-hand side. So before I go on to talk about the work we're planning in the Combat Candida program, I just wanted to mention a word of caution on using combination treatment for invasive candidiasis. This was a case report published recently where a patient with Candida auris failed treatment with echinocandins. I'm going to show you the graph here with all the drugs on. So firstly was given caspofungin and subsequently was treated with all the classes of antifungals. So you can see here, started with liposomal amphotericin B irrigation, then onto systemic liposomal amphotericin B with mycofungin, was then given a combination of voriconazole, flucytosine, and ibrexafungerp, and ended up on isavuconazole. And you can see from these boxes that by the time combination treatment was tried here, the isolate had already evolved some FKS mutations, FKS hotspot mutations conferring echinocandin resistance, which essentially meant that when the other drugs were introduced, these were sort of given as monotherapy and rapidly evolved resistance. This is giving combination as salvage therapy, which is often what we tend to do, when we're feeling desperate, and we don't have an evidence base for giving combination therapy up front. It's concerning to see this rapid evolution of resistance, but I think it emphasizes that we need a clinical trial to give us confidence to use combination therapy up front if it is beneficial, and it is, if we do get an evidence base that it's better for efficacy and it's a safe option, and this could prevent the resistance from emerging later on. So on that note, Combat Candida stands for Combination Antifungal Therapy for Candida bloodstream infections, and it's recently been awarded funding by the Wellcome Trust. This is a program of work including a randomized control trial to investigate combination treatment for Candida bloodstream infections. And we will be doing this at 5 sites in Johannesburg in the eye of the Candida auris storm, and this will be ongoing for the next 5 years, starting next year. So this will start with work program 1, observational study, much like the Candida study I've described in the UK, and it will enroll around 800 patients in ICUs at these 5 sites. We will take serial swabs from commonly colonizing sites, oral or skin sites, to track the emergence of antifungal resistance in relation to antifungal exposure. This will be done alongside a program of stewardship and IPC interventions, and will also describe the dynamics of transmission between patients and their environment by environmental sampling and sequencing. We will then take some Candida auris clinical isolates from patients in this observational study, and work program 2 will develop a murine model of Candida auris infection using these clinical isolates to really understand the effects of antifungal monotherapy and combination antifungal treatment. In parallel, we will finally run a randomized control trial of mycofungin versus mycofungin plus flucytosine for Candida bloodstream infections. We'll start with a dose selection phase to see if this reduced dose of flucytosine might be possible to use, and then we will continue using the optimal dose in a total of 450 participants per arm, and we'll use clinical, mycological and resistance endpoints to assess the efficacy as well as safety endpoints, which will be assessed using the win ratio analysis. So this is the team as it is so far. This will be led by myself and Nelesh Govender, by co-Is at St George's, Tahana Vichnich, Tom Harrison, Sheila Malloy and Jack Adams. Of note, there are several highlighted yellow people that we need to find. And if you are a clinician interested in research in South Africa, particularly interested in working with these lovely PIs at these sites, then please do get in touch. And I'd love to take any questions or comments or hear from you on any of the things we've discussed. Thank you.
Thanks, Rae. Really, really nice, and some scary statistics, like Evan is saying in the chat. His center seems to be the pupil of the eye of the storm, so to speak. And yeah, so I mean, I think it's wonderful this is being studied. I mean, I think that's the biggest takeaway for me from all of this, is that, you know, I agree with you. I think the evidence for combination therapy in many fungal diseases is a lot stronger than in bacterial, at least presumptive. And there's one way to settle it, and it's big proper trials to see what the answer is going to be, and what, you know, how the needle is going to move. I see Evans asking a question. Is there a virulence cost for increasing resistance in Candida? So is there sort of a trade-off?
Data to date hasn't been very compelling on that issue that I know of. Others might know of other data, but yeah, when studying virulence in animal studies certainly hasn't particularly been a concern. Clearly, clinical outcomes are going to be affected by the drug resistance and what drug you're using.
Okay. And then Tommy saying the macula of the pupil of the eye of the storm. So we're narrowing it down.
It's getting tenuous.
Yes.
Thanks, Evan. Good to hear from you.
Nosisa, do you want to ask your question verbally? Because I think that's probably easy. I think you should be able to unmute.
Thanks, Jeremy. I hate name changes, but I just wanted to hear whether you can comment on where does Candida glabrata fall under at the moment. Is it still a Candida, or is it this Narcolepsiomyces?
For me, it's still a Candida. I think it's confusing to change the names for clinicians, isn't it? Because the saying the treatments, you need to choose the treatments on the basis of this being a candidiasis. So I don't know, what do you do?
I stick with old names, but it can get confusing, and then you also don't know why is the name being changed. So I thought you might know, since these are your friends, all these different candidates and fungi.
Yeah, no particular comment on it. It's maybe just to confuse everyone. I mean, Krusei is a different issue. Maybe there's a bit less of a relation, but it's fairly rare, and particularly in South Africa. It's got a slightly different resistance profile to flucytosine as well. Slightly higher MSCs.
Speaking as a clinician, I'd far rather we have the old names taxonomically wrong than change the name, especially because it upsets the whole literature. Anyway,
I'm yet to find a clinician who wants to use the new names. I haven't found a single one.
I blame the microbiologist entirely. So Eunice is asking if Professor Eunice Musa from KZN is asking if one of the important reasons for combination therapy is preventing resistance, then don't you have to be careful that the combination has similar PKs and similar penetration into the sites of infection?
Yeah, that's a really interesting point. Yeah, I think it's something we've discussed and thought about. Clearly, we want clearance from these sites. One of the reasons is for patients to get better. If they've got an abdominal infection, we need to clear the infection from that cavity. But the other reason is for passing on resistance. So you're driving resistance in an underpenetrated site like the gut mucosae or the skin or the urine. That's transmissible resistance. So I think we haven't seen that issue arise in crypto or in other pathogens where we use combination therapy. But we need to monitor closely. And so, you know, that's why in the rigor of a clinical trial, we can really study in depth what's happening in the microbiome of every site. So taking any candidate isolated from patients on combination treatment from different sites, and looking at the MIC of not just the mycofungin, but also the flucytosine as well, to see if that is, you know, there is an indication that flucytosine MICs increase.
Yeah, no, fascinating. And then I just see that exchange between Nilesh and Tina Law, which is, I think, important. Just so there's issues getting 5FC in private, and Nilesh was just making the point that, so the myelin Viatris one is separate in section. You don't need section 21 anymore, but apparently they still have access problems to you know, in private, to getting stock literally from this company, even though it's registered, and so often have to go by section 21 for a different one, and then you end up with the same sort of access problem. So I think we do struggle. I mean, in the state sector here, I don't know if you're aware, Rae, but I mean, the National Department of Health has managed to not order enough stock for flucytosine for the last 2 months. So we're back to 10 years ago treatment for cryptococcal meningitis, but that, apparently that should be solved in the next couple of weeks. But still, you know, it's been a long process, and it's difficult. I think, you know, it's disappointing that we get these drugs, but it's very difficult to get access more than anything else. Not for cost reasons, just for logistics reasons, and
it's still definitely an issue. I mean, you know, I hope that, as with the story of cryptococcal meningitis, if we show this as a useful drug in candidiasis, it's another string to the bow of advocating and improving, you know, the access from the top, but also the logistical issues of getting this on the ground.
Yeah. And then I guess last question is how, so it seems that there's at least funding for the Canada study, which is wonderful, and that's all, I think, long overdue. So it's a really exciting, you know, study to get off the ground, and that's really wonderful. I mean, I wonder how you're ever going to get a study off the ground for mucor and aspergillus and things like that, and because they're all rare. I mean, I don't know if there's appetite at some point for people to put together one of those sort of each of 200 sites recruits 3 people type trials, but it's very difficult and very expensive, I think, you know, and very difficult to get that sort of trial off the starting blocks. But it's frustrating, because I mean, these are big and important questions in highly lethal diseases, but we don't seem to be even close to starting large scale, you know, well-powered trials on these sort of things. Platforms
are the future.
Yeah, I agree.
So, you know, we'll build our platform, and it joins with another platform, and we'll get some answers in the future.
There you go. As soon as you finished your Canada stuff, you can get on that.
Yeah, next on the list.